this one.
Well, I just must apologise because I was given that I had to talk about miscarriage, ectopic pregnancies and pregnancy of unallocation all in 20 minutes. So you're only going to hear little bits of it. Okay. So hopefully by the end of this session you'll be able to describe the ultrasound criteria to diagnose miscarriage and ectopic pregnancy. And then we're going to talk a little about defining the term pregnancy of unallocation and the possible outcomes. So the early pregnancy complications I'm going to be talking about failed intrauterine pregnancies, ectopics and PULs. So I put this up earlier just to show you hopefully how we scan, and the scan can either be diagnostic of pregnancy location or not. Okay, and now we're just going to take it a step further because obviously we also want to know with our intrauterine pregnancy group, do we have a viable pregnancy or is this a failed intrauterine pregnancy? Also, we want to know what's happened to these pregnancy of unallocation groups, so these women who we can't define the location or the viability of the pregnancy on that initial scan. And we want to find out who of these have got intrauterine pregnancies, who's got an ectopic pregnancy, and whose pregnancy has failed. So this is just a table that came up in the New England Review, I think earlier this year or last year, and it's just really to point out that when we're talking about whether a pregnancy is viable or non-viable, we have to be absolutely sure. Okay, and a non-viable pregnancy is any pregnancy that cannot possibly result in the birth of a live-born child. So obviously that's going to include ectopic pregnancies and failed intrauterine pregnancies. Now there's been a huge thing, certainly in the UK, in the misdiagnosis of miscarriage recently. Of course, you know, when we have a term baby, we would be absolutely sure there was no heartbeat on that scan. But are we using the right criteria in early pregnancy to say a pregnancy has definitely died, failed? So we need to be absolutely sure. So first of all, talking about failed intrauterine pregnancies. So really kind of, the term we use is miscarriage, and there are basically three different types of miscarriage certainly we will encounter when we're scanning. We're going to either have the complete miscarriage, where we can no longer see anything. Okay, the incomplete miscarriage, when there's a small amount of pregnancy tissue still left within the cavity of the womb, or we've got the miscarriage, when obviously there is a sac or an embryo still present, but we know that it's no longer alive. So first of all, talking about complete miscarriage. So the easiest way to diagnose this is if we've had a woman who's had a scan before that showed an intrauterine pregnancy. She will then have some bleeding, we rescan her, and we can see that the pregnancy has disappeared. Okay, and there is no tissue left. We've got a nice empty uterus. We can categorise this or diagnose her as having had a complete miscarriage. But the difficulty is in those women that turn up with a history of heavy bleeding who haven't had a scan before, and we scan them and we can't see anything. Obviously the history would be suggestive of her having had a complete miscarriage, but we don't know that for sure. And certainly there was a study a few years ago now by George Condus who followed up a load of women who all presented with what sounded like a complete miscarriage. But when they had a scan, we couldn't see any evidence of the pregnancy. And actually, when they were followed up, 6% of them actually had an underlying diagnosis of an ectopic pregnancy. So really, complete miscarriage cannot be a primary ultrasound diagnosis unless the woman's had a scan before. So this is just to illustrate this. So if this 30-year-old lady came in, last period was 8 weeks ago, she had a scan 3 days ago that showed that she had a viable intrauterine pregnancy. Unfortunately, she has some bleeding. We then repeat the scan, and we see here completely empty endometrial cavity. Our diagnosis for this lady would be that she's had a complete miscarriage. However, if the same lady came in and she hadn't had the scan before, we would have to label her as having a pregnancy of unallocation or a non-diagnostic scan and then follow her up. Okay, so a complete miscarriage is not an ultrasound diagnosis. So what about incomplete miscarriage? That's when we get some tissue left within the cavity. Okay. Now, it's really described as just having irregular heterogeneous echoes within the endometrial cavity. And there's some examples here, a little bit of tissue here, and a lot more tissue here. Now, what criteria do we use? How much tissue does there need to be in there? What's the endometrial thickness that we need in order to say someone's got an incomplete miscarriage? Well, actually, there have been lots of studies looking at cut-offs anywhere between 2 millimetres up to 15, 20 millimetres. And actually, they found that there's no real cut-off that can be used to diagnose an incomplete miscarriage. There were some studies where women even had endometrial thicknesses of less than 2 millimetres, but they went to because of symptoms, they went and had a curettage and they were found to have tissue still inside. So actually there is no definite cut-off, it's more just on the subjective appearance of there being tissue within the endometrial cavity. So here's an example here. So this lady comes in and you might scan her and think, well, what's actually this in the cavity? Is it blood? It does look all a bit thickened. What can we do to help us? Well, actually, this may be one of the occasions in the early pregnancy when we may use our colour Doppler, because if we put the colour flow on, we can actually see there's a little nugget of tissue here, which was actually some retained tissue. So that's something we can use to help us make the diagnosis. If in doubt of a woman having an incomplete miscarriage, if you're not sure whether that's a tiny nugget of tissue or not, the most sensible thing and the safest thing to do is obviously to treat them as a pregnancy indication and almost follow them up as a woman who'd had a query complete miscarriage. So the next type of miscarriage is what we call the miscarriage, where we've got an intact sac with or without an embryo, but we know the pregnancy has failed. But what criteria do we use to diagnose? And I know it varies hugely about what size empty sac you can have in order to diagnose a failed pregnancy. Does it have to have a mean sac diameter of more than 20, more than 25? And likewise, when you have a fetal pole, how big does it have to be without a heartbeat for you to be able to say that the pregnancy has failed? Certainly in the UK, these are the criteria that we now use, that our mean sac diameter has to be more than 25 millimetres, and it has to be empty, no yolk sac, no small fetal pole. Okay, and it's the mean sac diameter, so measured in those 3 dimensions that I should have told you earlier. And if we have if we actually can see an embryo, the crown rump length has to be more than 7 millimetres without a heartbeat. If, of course, you have an empty gestational sac less than 25 millimetres in diameter, the guidance is that we rescan in 7 to 14 days. Okay, and then if we've got a CRL that's less than 7 millimetres without a heartbeat, again, we want to rescan in 7 to 14 days. We know that there are studies looking at inter-observer error, okay, show that, you know, sometimes I might measure a crown rump length to be 5 millimetres, but then Christoph would measure it as 7 millimetres. You can just see by just twisting the image how I might make it 5 and Christoph would make it 7. And you could see how I would therefore say, let's rescan you in 2 weeks' time, whereas Christoph may then have made a diagnosis of miscarriage based on that scan, and the woman could have had an evacuation. So you can see how difficult it can be. So if there is any doubt, you rescan, and I think any woman would want to know, you know, you're giving her pregnancy the benefit of the doubt. And actually this is all guidance now that we use in the UK as a result of changes to the Royal College of Obstetricians and Gynecologists guidance and now NICE recommendations. So this is just to show another example. So this lady, I think this was a lady that was actually something like 15 weeks according to her last menstrual period, and we did the 3 sac diameters in the 2 different views. So we did 2 here and the 1 across here, and you can see, looking at the results here, we definitely had a mean sac diameter of greater than 25 millimetres, so we're able to diagnose a miscarriage. We're now also advised that we should have 2 operators to make the diagnosis. So you either want 2 scans a week apart, or you want this confirmed by 2 operators, is the kind of gold standard. And here are some examples of actually a miscarriage. So here we've got a fetal pole. Obviously, because it's not a video, I can't show you that there was no heartbeat, but we had a CRL measurement of 15.4 millimetres, and one here with 10 millimetres, and you can just see how there are other subtle signs at how disproportionately small this appears compared to the gestational sac. There are other subtle things that we can see on scan that are indicative of a miscarriage, but you can't actually use it to confirm a miscarriage. Okay, so we've got this pregnancy up here, up in the top left. So we've got our fetal pole here with our gestational sac, and all around here we've got a very big subchorionic hematoma. Okay, the significance of small subchorionic hematomas, probably nothing, probably just explains why the woman's got a little bit of spotting. But some of the bigger ones obviously does put them at increased risk of miscarrying. We've got other signs here, so very large yolk sacs. Okay, again, not a good prognostic feature. If you scan a woman who says she's 5-6 weeks and you just see a big yolk sac, you can't tell her pregnancy has failed, but you should be realising that this isn't a good sign. And obviously this would be someone you definitely want to come back. Okay, now I'm going to swiftly move on to ectopic pregnancy. Okay, we now know that transvaginal ultrasound has really become the diagnostic test of choice for ectopic pregnancy. And whereas initially, when we were diagnosing ectopics on scan, it was looked that we had to just not see an intrauterine pregnancy, we're now looking at positive visualization of the actual ectopic pregnancy. So I'm just going to run through now what we would see with an ectopic pregnancy. And we're really going to be looking at 3 areas. Of course, we always assess the uterus first. We're then going to assess the pelvis for free fluid, and then look at the adnexa, clearly looking at the ovaries, and then looking to see if we do actually have an ectopic in the tube. So what do we see when we scan the uterus in a woman with an ectopic pregnancy? Well, most of the time we probably see nothing. We probably have a nice empty uterus. Okay. Sometimes we see some fluid in the endometrial cavity. I'll talk a little bit about that more in a moment. But of course we may see our early intrauterine sac. Just because we can see an intrauterine sac doesn't mean, in a woman with pain, or anybody, that we shouldn't be going over and looking at the adnexa. Because we do know that we can have this. It's not the best image, but you've got a little pregnancy over here in the uterus and one right over here in the tube as well. So a heterotopic pregnancy. So this is important when you know the woman's had IVF, she's had 2 embryos put in. You've got one in the uterus, you want to know where the other one's gone. So the endometrium, unfortunately, we know that there's no specific endometrial appearance that's suggestive of an ectopic pregnancy. So we can't just look at the endometrium and say this woman has an ectopic pregnancy. We know in about 20% of cases we'll see some fluid within the cavity, which is often termed the pseudo-sac. And I think I've got here now, my next slide is these are literally 4 women that I've all seen that all have been diagnosed with ectopic pregnancies in the last month or 2. And I just wanted to show the variation in their endometrial appearances. So you've got this one here, which almost you could initially think, oh gosh, is that an incomplete miscarriage? Is there something left in the uterus there? You've got this one here, who almost looks like she's got a periovulatory triple line appearance to her endometrium. Got this lady here that's got some blood in the cavity, as does this one, just some fluid in there. So you can see there is a huge variation in the endometrial appearance. The other thing we may see on scan is, of course, blood in the pelvis. So echogenic fluid with our uterus floating within it. Okay, of course, yes, it may be suggestive of having a bleeding ectopic pregnancy, but again, we know corpus luteum can rupture in pregnancies where they're intrauterine. So it's not diagnostic of an ectopic pregnancy, but we'd be highly worried that a woman may have an ectopic pregnancy if you see a lot of fluid within the pelvis. We do, however, know that it's very common to get small amounts of anechoic fluid even with intrauterine pregnancies. And certainly we found about 50% of our ectopic pregnancies has some kind of fluid within the pelvis. We know that blood in the pelvis is probably significant if it reaches above the fundus of the uterus. It's amazing when you see a little bit of fluid, and I always get very excited, think, oh, there's blood, and actually you put the calipers on, you measure it, and it's about 10 mils of blood. Okay, so it's only really significant when you can see big pools of it above the fundus of the uterus. So what about actual visualization of the ectopic pregnancy? Now, first of all, I'm going to be talking about tubal ectopic pregnancies. So they're about 95% of all ectopic pregnancies. Probably the easiest ectopic pregnancy to see is the one where we see a gestational sac in the adnexa that contains an embryo. And if that embryo's got a heartbeat, it's even more obvious what it is. It can't really be anything else. Okay, and here are some examples here of just with ovaries to the side and with gestational sac with an embryo and fetal poles. But we only see this in about 20% of the ectopics we see. Okay, and only about 5% overall of ectopics will actually have a heartbeat, and that really represents that we're picking up and diagnosing these earlier. Again, these are some further examples of ectopic pregnancies where we see the CRL. This one gave me a huge amount of heartache, 43.7 millimetre embryo. And this was actually picked up on her 12-week scan. I actually got called to the nuchal scan to see that one. The next thing we may see is just an empty gestational sac in the adnexa. So it's almost like seeing a 5-6 week pregnancy that's just in the fallopian tube. So we see gestational sacs that don't contain anything. Again, we see that in about 20% of cases. Again, a couple more examples showing that. By far, though, the most common thing that we see with an ectopic pregnancy is just an inhomogeneous mass in the adnexa that moves separate to the ovary and quite distinct from the corpus luteum. In this, we see them about 60% of cases. These probably represent one of two things. The smaller masses may well be small growing ectopic pregnancies. And I know for some experience, in some cases when we see this in a woman who doesn't want any treatment, if we leave it long enough, we will then see a gestational sac appearing within this mass. Okay, others, probably the bigger masses, represent where there has been bleeding and hematoma into the fallopian tube. And actually, I've got a nice image here that shows the ovary up here and the ectopic here. This is on one image, and then we twist it and rotate. You can actually see this is all the fallopian tube, and it was all hematoma. And when we took her to theatre, she did have a big ectopic in that tube. Of course, as I said before, 95% of ectopic pregnancies are tubal, so 5% are the non-tubal. It's not. We tend to call an interstitial ectopic pregnancy a non-tubal ectopic pregnancy, but of course it is in that interstitial part of the fallopian tube. Okay, so it's when you get it, it's separate to the ectopic pregnancy is seen separate to the endometrial cavity, but it's still surrounded by myometrium. These are thought to happen about 2 to 4% of ectopic pregnancies. They're often termed a corneal ectopic pregnancy, but they are not the same thing. A corneal ectopic pregnancy, and you can see I've not got any ultrasound images of them because they're very rare. This is when you get implantation in the non-communicating horn of a rudimentary horn of a unicornate uterus. So this is an ectopic pregnancy in an abnormal uterus. Okay, so very rare, 0.2% of all ectopic pregnancies. Cervical ectopic pregnancy is a little bit more rare when you get it embedded actually down in the cervix. So you've got an empty uterine cavity up here, you've got barrel-shaped cervix, the gestational sac is implanted below the level of the internal os. Okay, the thing with this is, how do you know whether it's a sac that's a miscarriage in evolution or it's actually embedded within the uterus? Okay, within the cervical canal. So we do use Doppler to find out if there's any peritrophoblastic flow. We can also look for the sliding sign. So what we actually do is put our transvaginal probe in and actually put some pressure on the cervix using the probe. If it's a miscarrying sac, you'll normally see it moving. The other thing with these is that you repeat the scan. If it's still there a day, 2 days later, you've probably got your diagnosis. The next type of an ectopic that people get very excited about these days are the Caesarean ectopic pregnancies, or whether it's truly an ectopic is another whole lecture. But this is when you get implantation in the presumed site of a Caesarean section scar. Okay, again, like many of the other, with all ectopic pregnancies, you're either just going to see a mass, you're going to see a gestational sac, or a gestational sac containing an embryo or a yolk sac. Okay, so this is thought to happen now in about 6% of women, 6% of ectopics in women with a previous Caesarean section scar. Another type of ectopic, an ovarian ectopic pregnancy, again, very, very rare. You're seeing the ectopic actually within the ovary. Okay, the key to this is seeing it seen separate to the corpus luteum. Another type is an intramural. This is when you get implantation within the actual myometrium. So not in the fallopian tube, not in the cervix, not in the uterus, actually within the myometrium. So that we have normally done something to the woman to damage her myometrium for her to get this in the first place. Okay, but they're rare. Hopefully you're not going to see this. Okay, what you are more likely to see is a heterotopic pregnancy. Okay, we know these are much more common, so it's any of the above types of ectopic pregnancy in conjunction with an intrauterine pregnancy. It's thought to be about 1 in 30,000 spontaneous pregnancies, but that is just a kind of statistical calculation based on the risk of a dichorionic diamniotic pregnancy multiplied by the risk of an ectopic pregnancy. Okay, in reality, it's probably about 1 in 7,500 natural conceptions, so we probably will all come across one at some point. The other thing that I think probably you're more likely to pick up later in the pregnancy than we do in early pregnancy is the abdominal pregnancies, okay, because these women normally haven't had a scan early on. And there are two types, one where you've just got primary implantation within the peritoneal cavity, and secondary where it's actually a result of a tubal abortion and reimplantation. Again, rare. So having taken you on a whistle-top tour through ectopic pregnancy, if I've still got some time, we'll do pregnancy of elongation. Okay, so pregnancy of elongation is when we scan a woman in early pregnancy and we have no evidence of either an intrauterine pregnancy or an ectopic pregnancy on the scan. We know it's accepted criteria, recognised terminology from a lot of big organisations. In fact, there was a consensus statement at ISUOG conference in 2006 looking at what are accepted PUL rates, etc. Okay, we know that in the literature, anything between 5 to 42% of women attending for a scan in early pregnancy may be classified as having a pregnancy of elongation. Fortunately, though, from specialised units that published data, we know PUL rates are very relatively low, about 8 to 10%. So ISUOG thought that we should actually be trying to maintain our PUL rates of less than 15% in any early pregnancy unit. We know that the PUL rate depends on a number of things. The gestational age of the woman, as I've shown you earlier. If you scan everybody as soon as they've had their new home pregnancy test that's detected, 3 days post-conception that they're pregnant, of course, you're going to have a very high PUL rate. It's also going to depend on your operator experience, the ultrasound machine, whether you're doing a transabdominal or transvaginal. Actually, for a pregnancy of elongation, we're assuming that you've performed the transvaginal scan. Other things that get in our way, big cysts, fibroids, they all increase the risk of us not being able to see the pregnancy. This is really data from the diagrams I showed you earlier showing that we get, the earlier you are in the pregnancy, the higher the PUL rate. But of course, our PUL rate never comes down to nothing. And that's normally because the women later on that are at 9-10 weeks, these are the women that are presenting as complete miscarriages, with the end term as pregnancy of elongation. So really, what's the etiology behind a pregnancy of elongation? And I've alluded to this earlier. It's either because, 1, the pregnancy is too early to be visualised, 2, the pregnancy's already failed and has already gone, so we're a complete miscarriage, or 3, we've got an ectopic pregnancy there that's either too early or we can't see it. And I've put down here in asterisks at the moment, it's a classification term only. It's not a diagnosis. Okay, this is kind of a working diagnosis until we've actually been able to work out whether the woman has got an intrauterine pregnancy, has had a miscarriage, or has got an ectopic. So how do we classify a woman as a PUL? Well, it's really important we really examine the endometrial cavity, looking for anything that might resemble an intrauterine sac. We want to clearly visualise both adnexa. You can't be termed a pregnancy of elongation if you haven't looked at the adnexa, because there might be a big juicy ectopic sitting right there. The other thing is we want to inspect the pouch Douglas, looking for any fluid. And the other thing is we want to look in those other areas where we know pregnancies can hang out, such as the areas with those non-tubal ectopic pregnancies. So it's really important that we go through the cavity and look out at those interstitial areas of the fallopian tube. So why might we call a woman a pregnancy of elongation when in fact she's only got an early intrauterine pregnancy? Hopefully, as I've told you earlier, we don't see a sac until she's 4+ weeks. Okay, so the most likely cause is that she's just less pregnant than she is. Even if you have women coming in absolutely adamant how many days pregnant they are, they knew when they get pregnant. We know they get their dates wrong. Cycles vary in length. It's very easily, and every day makes a difference at this early stage. What about PUL, or is it a miscarriage? As I've shown you before, we do know that women with heavy bleeding Although it sounds like a complete miscarriage, 6% of them will have an underlying ectopic pregnancy. So it is important that we follow them up. And of course, we're often basing this on a woman reporting that she's had heavy bleeding. Heavy bleeding for one woman is spotting for another. Okay, so it's very variable. We don't trust women, we have to follow them up. The other thing is it a PUL or is it an ectopic pregnancy? Now, of course, I've done some work looking at what percentage of ectopic pregnancies we see on the first scan. We only ever actually managed to see about 3/4 of our ectopic pregnancies on the first scan. About a quarter will arise out of the pregnancy of unallocation group. And we've shown that actually we haven't just missed them, they're probably just too early to see. So women who have pregnancy of unallocation, who have underlying ectopic pregnancies, they tend to be women who've presented very, very early with very low HCG levels, and we're just scanning them too early, rather than having big ectopic pregnancies that we've missed. Fortunately, though, not all women with a pregnancy of unallocation have an ectopic pregnancy, and this just shows you the general outcomes. And actually, the majority of women with a PUL actually have failed pregnancies, okay? And we're just really scanning women that years ago would never have come to us, okay? So PUL is a bit of an iatrogenic problem. So hopefully, I've taken you through these learning objectives that you now can describe hopefully the criteria that we use to diagnose ectopic pregnancy and miscarriage, and hopefully you now know about the term pregnancy of unallocation. To really summarise about failed pregnancies, you should only be terming a pregnancy failed if you know that there's absolutely no way it can result in the birth of a live baby. If in any doubt, you're going to rescan in 7 to 14 days. It's much better that a woman is told that and then she miscarries before she comes back for the repeat scan than that you inadvertently terminating what could potentially be an ongoing pregnancy. And obviously the criteria to diagnose miscarriage, certainly in the UK, have certainly changed in recent times to avoid the misdiagnosis of miscarriage. With regard to ectopic pregnancies, now more than 90% should be visualised on ultrasound prior to treatment. Of course, we should be trying to positively identify the ectopic rather than just excluding an intrauterine. We know that 3/4 will probably be seen on the first scan, but 25% will arise out of your pregnancy of unallocation group. And with regard to pregnancy of unallocation, we know it's a classification term only. All the women need follow-up, and you can be reassuring to your women that majority don't have an underlying ectopic pregnancy. And that's it.
Thank you very much.